12:22 p.m. 360 security. Lock unlock button. Device unlock. Apps list. Gmail. Inbox. Selected. Mail. 3 new notifications. Mail. In list. 2 items. Unread. We sent you a $851.24 check in. Delete out of page. Unread Beth Mark. You might want to mute in pager. Reply. Double tap to activate. Reply. Gmail. Compose. Showing English. US QWERTY keyboard. Open feature. Capital. Space. M. Space. M. O. N. Space. M. U. T. E. Period. Mute. Space. Capital C. Can. N. Can. Y. U. Space. H. E. A. R. Space. N. E. B. Symbol keyboard. Send. Sending. Mail. Symbol keyboard hidden. Sent. Email. 2 new messages. 2 new messages.
I just went through and I made all my files.
Hi, Beth and Karen.
Thank you all so much for being here. This is our last spring session of the Equity Inclusion Committee's Meet and Learn series for this academic year. I'm so excited to see so many people here. The event will be recorded so that you can earn continuing education hours if you watch the event and fill out the Qualtrics survey after the fact. So for those of you who are watching this after, thank you. Today we have a great topic. We have Jen Glayzer and Sabrina Jamal-Eddine, who are PhD students, PhD candidates, who are going to be speaking to us about being nursing students and nurses living with disabilities, and how we can best support students and others who are living with disabilities, hidden or apparent. So we really appreciate their expertise on the topic. And I'm going to let them each introduce themselves a little bit further for you as we get started. And we will go ahead.
Sweet, thank you. I'm gonna share my screen. Okay. All right, so this meet and learn we are doing on the disabled student experiences in nursing education, and we're going to be talking about ways to support and advocate. So I'm going to be doing the first part of this presentation, and then Jen is going to take over the second part. So we're just going to start with my introduction first. I'm going to start with a positionality statement, and this is one component of reflexivity, and it's basically the way that our intersectional identities and intersecting positions of power and oppression inform the way we read, experience, and articulate the world. So it's important to start with those. So my name is Sabrina Ali Jamal-Eddine, and my pronouns are she, her, hers. I am an Arab, brown, culturally Muslim, disabled, middle-class, queer, cisgender American woman, spoken word poet, registered nurse, and nursing PhD student living in Chicago. And then I'm also going to do a self-description statement for increased accessibility. So for those of you who aren't familiar, and it's not something that I've seen used much in healthcare education, this is a brief description verbalizing what you as the speaker look like for those who are low vision or blind. And then it's also beneficial to sighted people who are driving or just listening auditorily. So this is a really good first example of the way that universal design and centering the people with intersecting oppressions benefits everybody, disabled and non-disabled alike. So here's my self-description. I am a young woman with light brown skin, dark brown curly hair that is pulled up in a bun, brown eyes, and I'm wearing a brown cutout sweater. And behind me is a black and white sun and moon tapestry. And then just a little bit about me and my work at UIC. I have just a couple weeks left in my third year as a nursing PhD student with a focus on disability studies and critical pedagogy at UIC. I'm studying the use of spoken word poetry as a form of critical narrative pedagogy to educate nursing students and instructors about disability, ableism, and disability justice. And at UIC, I am a university fellow. I serve with Jen on the Chancellor's Committee on the Status of Persons with Disabilities, and I also serve on UIC Senate, the 2022 Chancellor's Search Committee, and I am a teacher's assistant, and yeah, so, all right. I'm gonna start off with telling my story of basically my story with acquiring disability, and then my experience within nursing education of attempting to earn my BSN at a different university while being disabled. And normally I would do this in the form of spoken word, but I'm going to do it as a regular narrative right now. But okay, so basically, back in 2012, I underwent a 12-level posterior spinal fusion to correct a curvature in my spine that consisted of breaking my back in 3 places and inserting cadaver bone graft, 2 rods, and 18 screws. in my back. And then the minute that I woke up from surgery, it started to hurt to breathe. It felt like someone was cutting me with a knife every time I inhaled, and every time I moved my arms like above chest level, it worsened that scraping feeling in my back. So prior to getting the surgery, the surgeon had said that this would be minimally invasive and that the surgery would take 2 hours, that I would have 3 small 1-inch incisions, and that I'd be up and walking around the mall in 3 weeks. But in reality, the surgery took 6 hours. There wasn't even a 1-inch gap between my scars. I was primarily bedridden for about 3 months. And then when the nurses first removed my bandages, that was the first time I ever saw my dad cry, because we all knew that something had been wrong with what we initially thought the surgery was. And then the breathing pain didn't go away. And then 6 months after my surgery, over 500 medical malpractice lawsuits broke out against the surgeon when patients realized that he had been purposefully failing surgeries and performing multiple revision surgeries on every patient, drawing in like mass amounts of money on each patient. So then as a junior in high school, I went from navigating school and my social life on my own to needing someone to meet me at my car every morning to lift my backpack, someone to help me open doors, needing to use the elevator, needing someone to carry my things in between classes. I had to carry a pillow with me to every class because my screws were really painful when I sat against the chairs. But my high school was extremely accommodating, and they only required me to attend 5 bells per day instead of 7 so that I could manage my pain better. And they allowed me to use the elevator and made sure I had a friend to help me carry bags in between classes, or a staff member if I didn't. They really viewed accommodations as equity rather than unfair advantages. And they knew that if I was sitting in that class, in the classroom for 9 hours a day, I'd be forced to focus on my pain rather than actually focusing on the content of the classes. So I was no longer able to do a lot of the things I used to do with friends, like hiking, playing soccer, going to concerts or dances. And the only thing that gave me relief from my 24/7 breathing pain was my friend would come over after school every day, and I would lay down on the floor and she would put all of her weight on my scapulas, and that would give me like the relief from the breathing pain. So I would have like 15 minutes a day where it didn't hurt. And then my friends were really great and gave me back massages all the time to help with the pain of the rods going into the top of my back. When I had seen about 5 surgeons after the malpractice surgery, and they would ask me for the surgeon's name. I would say the surgeon's name, and then they would say, sorry, we're not getting involved, even though I didn't have a lawsuit or anything. I just wanted to correct the breathing pain. And I just remember like the trauma of sitting in the car with my mom after every one of those doctor appointments and just like crying so hard because I couldn't imagine like still having the 24/7 breathing pain. It was scary to me. And then my mom ended up sending my CT scan to somebody in Maryland who wasn't familiar with the surgeon who did the medical malpractice. He said it was pseudarthrosis, which is failed fusion. And then the next surgeon that I saw in Cincinnati said the exact same thing and offered me a revision surgery. So I was at my other university, I was approved for a year-long medical leave of absence so that I could get my revision surgery, and they were really great and held all of my scholarships so that I could get the surgery. And then, so the new surgeon removed the 2 rods and 18 screws and put in a new set of properly contoured hardware. And then the minute that I got out of that surgery, it didn't hurt to breathe anymore, but I have had long-term trauma on my spine from the first medical malpractice surgery that left me with a permanent physical, non-apparent acquired disability. So I still have 2 screws that protrude at the T7 level of my back, and I get random sharp breathing pains at some point every day. And my biggest limitation is lifting because it makes my screws protrude. And accessibility wise, the only thing that relieves the pain when I am having the breathing pain is to lay down in bed. So that's why virtual education has been extremely accessible for me. And then if I sit without a cushion behind my back or a pillow, my screws will cause me a lot of pain. So basically, it was my experiences with healthcare and disability that motivated me to pursue nursing in the first place. Like, nurses were very central to my healing process. And it's literally been 10 years since my first surgery, almost 10 years now. And I still remember like the name of the nurse who was like just really humanized me and showed me so much empathy and love. Her name was Kip. And I also remember the nurses that didn't show me a lot of love and like left my catheter bag to overflow. And I remember the feeling of, it was like a sensation of urine going back into me when my catheter bag was full. And then also just like having 2.5 years of incessant breathing pain showed me like the need for accessible quality healthcare as a human right rather than a privilege for those who can afford it. I think that my disability showed me a level of compassion and humanness that I had never previously experienced or been exposed to. It allowed me to disrupt like the patient-nurse dichotomy because I spent a lot of time as a patient. And I gained an introspection into what it feels like to be a patient. So throughout both of my hospital stays, I experienced JP drains, 2-liter blood transfusions, catheters, narcotic-induced constipation, suppositories, 16 heparin shots, 8 blood draws, IV bruises, and the indescribable pain of being turned every 4 hours when you've had the majority of your body cut open and manipulated. I've experienced the way that PCA pumps with morphine drips don't relieve any pain when you've had such a major surgery. I learned how to manage taking 36 pills a day, the frustrating process of physical rehabilitation, which is just extremely slow, loss of dignity and perceived independence, as well as just like altered body image and abilities. So for all of those reasons, I was attracted to nursing as a profession, and I wanted to become a women's health nurse practitioner because I thought that would be a really accessible route within nursing for me, and I was always really interested in women's health. So once my year-long medical leave of absence was over, I began my prerequisite coursework at the university, and I worked nonstop that year because the BSN program was extremely competitive, which is just a euphemism for exclusive, but they only admitted 160 students out of 600 applicants each year. So I studied nonstop and I got into the program, and I actually wrote about my disability within my application essays, since that was a big reason why I wanted to go into nursing. And then I quickly realized that nursing didn't reciprocate its love for me. So like at the bottom of every syllabus, they post a statement saying to come forward if you have any kind of disability or need any accommodation. So I did that. I went to my clinical instructor during my first clinical, explaining that I just might need help lifting patients up in bed, and explaining that my intentions were always to become a nurse practitioner. Like, I have never had any intention of doing bedside nursing. And the clinical instructor said she would need to talk to the Med Surg 1 course head about it. Then within a couple days, I got an email from the course head asking me to meet with her in her office, which I did. And when I entered the room, she questioned why I chose nursing as a profession in the first place when I was not physically able to do the work. She handed me a list of technical standards and said that I signed this when I applied to nursing, and that if I don't meet any of the physical or ability requirements, that I can't be there. She said, "What's next? You can't even lift an IV bag." And I remember crying really hard. I kept it silent while I was in there, but it was, I couldn't hold like my tears back from hearing that, because you work nonstop for something, to have someone tell you that you can't be there because of something you have no control over. It's also something that you've already thought about before going into the major. And then the director of the program called me to talk about my disability and said maybe I need more time to heal before she asked me if I wanted to get another year of medical leave of absence, which it had already been 2 years after my revision surgery at that point. At that point, I didn't need healing. It was a permanent disability. And I was also crushed after that call. Just like being punished for something you have no control over is really harmful and traumatic for these students, including myself. And then the director told me that I needed to submit substantive proof from my surgeon, giving me permission to even stay in the program. So I went back to my surgeon. He didn't understand why they would say that. He said, "I know you don't have any intention of working bedside. There are doctors in wheelchairs and nurses who acquire physical disabilities from the profession, which is literally a disabling profession. If they can find a place in nursing, so can you." So he wrote me the letter granting me permission to stay. And then at that point, I vowed to never say anything again to an instructor about my back disability. After I turned the letter in, the faculty like brushed it under the rug, like I could stay there. And I went on silently with my program in a lot of pain, although my peers were really helpful. Like, so I ended up just going to them instead of going through a professor, and every clinical rotation, they all knew about my back and provided me a lot of like interdependence with when I needed help lifting someone in bed or things like that. So I had that was very helpful. And then I also got registered with my Office of Disability Services at my previous university, only to witness a really strong disconnect between helping, like they didn't know how to help someone in a clinical major. I think a lot of their experience is helping people in non-clinical majors. So I was offered like extra time on tests, which I didn't need and never used, and like random things like that weren't really helpful for me. And I think there's just like a lot of lack of clarity on these technical standards and people with disabilities. But I told, so like my final year in nursing, I felt like I was far enough in the program where they wouldn't kick me out for it. So like I had made it far enough. So I came out to one of my professors about it for my med surg 2 clinical, because I just couldn't take like the pain anymore. And she was like super welcoming and made a really inclusive space for me. She explained that she had a back disability and that she acquired from nursing, and she said nursing is a team profession and there's 7 other peers in your clinical rotation who can help you, and that nurses always help each other. And that was like, yeah, like the first clinical instructor who made me feel like I belonged in nursing and that I was an asset to the profession. And then my community nurse health instructor was also very similar with that. And then, so yeah, I found throughout my time in undergrad, I found a lot of safety in spaces outside of nursing. I work 2 part-time jobs for the Nursing Diversity, Equity, and Inclusion Student Advocate, and worked for the Department of Social Change. And I ended up earning my RN license, and my mentor from the Diversity, Equity, and Inclusion Department at the University College of Nursing pushed me to look into a PhD because she knew that I wanted to create wide-scale systemic change, and she liked my grant writing skills and just like my desire to focus on marginalized people in healthcare, specifically disabled patients, nurses, and professors. And then also just like the accessibility of a PhD pathway is really helpful for a lot of disabled people, and the lack of women of color in nursing faculty positions. There were a lot of reasons why I decided to pursue my PhD, but just in general, I think like nursing is a really accommodating profession because there are many inherently accommodating avenues within nursing. So the nurse practitioner, DNP, PhD tracks, as well as outpatient, telehealth, informatics, administrative nursing that many disabled students who are passionate about nursing have trouble accessing in the first place because of traditional general BSN programs and this toxic med-surg first culture that views bedside nursing as kind of like a rite of passage. Kind of like you're not a real nurse until you've gone through several years of bedside nursing, which I heard a lot throughout my time in undergrad, and that's just really ableist, and also ableist technical standards, and faculty contribute to disabled nursing students not being able to access nursing as a profession. But so yeah, that's my story and experience with it. And there are a couple of things I want to touch on within my story and other disabled nursing student experiences before I move on to the really broad overview of disability education. But the first element is trust. So disabled nursing students experience an overwhelming lack of trust from nursing faculty related to their disabilities, and this is really bi-directional. So in that basically nursing faculty lack trust in disabled nursing students because of ableism, pathologizing disability, and disbelieving students. And then at the same time, disabled nursing students lack trust in nursing faculty once their trust is broken by threats against their safety within the program. So there's like this misbelief that accommodations are unfair advantages that privilege disabled nursing students, and that if nursing students need accommodations, they should not be in the profession, which is what I experienced. And this is the basic difference between equity and equality. But these like unsafe, traumatic experiences, like bi-directional experiences of distrust, force nursing students into one of two pathways. So I think the first pathway is non-disclosure and silencing or hiding. And basically like hiding for the sake of safety and their right to stay in the program and just get through the program, which is basically what I did and with my undergrad experience. And then also the pathway of hyper-disclosure, where students, and this is kind of where I find myself at now within a PhD program, is students feel the need to overshare in order for their professors to legitimize their accommodations. Like I know that I'm not required to disclose everything that I disclose, but I still do it just because I feel like professors will view my accommodation as laziness or an unfair advantage because they have in the past. It's kind of like when one nursing faculty traumatizes a disabled student, then they have this defense mechanism against all nursing faculty. So that's why it's really important to stop these individual cases of ableism from happening. And then I haven't had this issue personally, but I've also heard issues specific to nursing students and professors, where like nursing is really unique because these nursing professors are simultaneously professors and also healthcare providers. So this can sometimes cause like invasiveness where the professor will ask more than they're supposed to, thinking that they're helping the student, but actually going too far with like, one person told me that like they'll assume healing times and that kind of thing, and like ask for blood values and that type of thing. And like, yeah, it's just like nursing faculty are in positions of power within the harmful student teacher dichotomy that we have, and faculty really need to be cognizant of this power, this position of power over students, and foster a relationship of trust with their students. So when faculty break students' trust and they perform any act of ableism, racism, classism, homophobia, sexism, Islamophobia, transphobia, or xenophobia, like that is breaking the trust for the students. So yeah, just like being told that I couldn't be there because of an identity I had no control over is what broke my trust. And feeling the need to overshare about my disability in order to have the professor respect my accommodation is also a symbol of broken trust. So feeling the need to fight for an accommodation is breaking the trust. And professors really need empathy, understanding of equity, and education about disability and ableism. Okay. So nursing faculty as gatekeepers. So faculty who in the context of US nursing are primarily white Christian heterosexual cisgender women serve as the gatekeepers of the profession. This means that this group of people have the power to decide which students deserve to become nurses. They have the power to decide which type of disability should be accommodated for. And for some reason, only learning disabilities and temporary disabilities are usually accommodated for. My presumption is that learning disabilities are more commonly accommodated for because of the Disability Resource Center or Office of Disability Services, which has a lot of experience with accommodating for those disabilities. And then temporary disabilities, I noticed a lot in undergrad, were really accommodated for. So if a student had a broken arm or a leg, they were accommodated for. And I think it's because there's still a viable prospect for resumed able-bodiedness. So it's really silly that they feel fine accommodating for a broken leg, but only for one semester when clearly they know how to accommodate for it. Anyways, and then disability as an asset to nursing. So when it comes down to it, there is immense value in having providers with personal healthcare experiences, histories, and disabilities serving patients. We bring lived medical and disability experience, diversity, empathy, creativity, and problem solving and advocacy skills, as well as medical or disability concordance to patients that no other practitioners can provide. It's something as simple as like my brother he got appendicitis a couple months ago, and then he needed an urgent appendectomy, and his nurse had had an appendectomy before, and that comforted him, and the nurse was able to give him tips from personal experience. It's just we bring like a much deeper connection to nursing than just the typical combination of job security, flexibility, and wanting to take care of people, which is what I heard from 90% of the students in my undergrad program. We want to be there because of our disability culture and our community, because we experienced or continue to experience pain, suffering, and healing, and want to be a part of that human experience with others within our community. Disability is a culture, and just like cultural communities associated with race, ethnicity, nationality, sexuality, gender, and religion, disability shares those elements of culture with each other. And then, all right, so I'm going to jump into the education on disability, and this is going to be extremely not covering everything that I want to talk about, but we have a time constraint. So much like the way that this was also only like 1/10 of my disability story when I was doing the story. I'm just going to go in on ableism. So a lot of times people know what racism, classism, and sexism are, but if you say the word ableism to a medical provider, for example, a lot of them have never heard the term or don't know what it is. And disability is almost entirely left out of nursing and the medical curricula. So discussions on ableism are even more absent. And ableism is defined as discrimination that favors able-bodied people or the unintentional or intentional prejudice against people with disabilities. And ableism is reflected in our systemic policies and practices, our attitudes, language, physical environments, and technological developments, which foster the exclusion of and the oppression of people whose bodies deviate from the socially constructed ideologies of normalcy. The medical field's historically implicit and overt push for normality through medically unnecessary treatments that bring bodies closer to the range of normalcy, as well as the medical institutionalization of disabled people and the objectification and disposal of disabled bodies are all really good examples of the way that ableism is literally ingrained in medicine's history, much like racism. But a historical analysis of ableism in medicine is beyond the scope of this presentation. But the fact that healthcare works so closely with disability and that disabled people comprise the largest minority in America legitimizes the need for nursing to position itself as a leader in disability-focused research and advocacy. So to begin, the difference between disability and impairment. So impairment is the corporeal, physiologic, or psychologic, medically defined condition of the body or mind resulting from disease or injury that includes differences in physical appearance, functioning, pain and fatigue levels, and or communication abilities, versus disability is the socially constructed experience of living in a society which disadvantages, excludes, and fails to accommodate for individuals who have the aforementioned impairments. So impairment is biological, while disability is a social construction, and disability is the experience of barriers and exclusion based on impairment. So those are good to know the differences between. And then social versus medical model of disability. So the medical model of disability basically says that pathology or deficit exists within the disabled individual, versus the social model of disability counters that pathology or deficit rests within the hegemonic social environments that refuse and fail to accommodate for corporeal diversity. So inaccessible environments thus cause disablement of impaired individuals in society. So that's like a basic overview, and the medical field primarily ascribes to the medical model, and disability studies, disability culture, disability activism leans towards the social model of disability. And then I want to talk about the difference between person first and identity first language. So you've probably heard me use the word disabled over 100 times now throughout this presentation and to describe myself. So just to start this off, disabled is not a bad word. There's a difference between person first and identity first language. So person first language would be saying person with a disability, versus identity first language would be disabled person. And I want you to note that both terms usually include person within them. It's just a matter of the order. So the disability studies community generally accepts and honors both of them, but within disability justice, disability activist, and disability culture community, they typically lean towards identity first language or using the term disabled person as a means of subverting the idea that disability is an inherently negative thing. So for example, I am an Arab person. I don't say I am a person with Arabness because there's nothing inherently offensive about my identity as an Arab person. Likewise, we don't say a person with Blackness, a person with queerness, a person who is Muslim. No, we say an Arab person, a Black person, a queer person, a Muslim person. So because we don't view those identities as inherently bad words, it's okay to use the identity to describe the person. So treating disability any different is problematic. It implies that there's inherently something wrong or offensive about impairment or disability, and that it requires additional humanization, when in reality, it can be offensive to associate disability with negativity, pathology, or dehumanization. So the healthcare field still runs on the medical model of disability, which quite literally believes that impairment and disability is pathology, that it is something that everyone would want to get rid of immediately if they could, that it's something to be ashamed of, and that it's an insult. And when it comes down to it, the person experiencing disability should have autonomy over the term that they choose for themselves. However, to make the default person with disability, which is what we do in the medical field, can also be problematic and obsolete. So a lot of times also different communities within the disabled community prefer a different one. So listening to or researching what they prefer as a community could be useful, but there's no reason to privilege person first language over identity first language. And this requires educating healthcare providers, instructors, and students that disabled is not a bad word. Disability is not a bad thing. It's not something to be scared of. So this is also a really good representation of the really bad separation between healthcare and humanities, and the way that healthcare is so separated from disability studies despite healthcare working so closely with disabled people. And then medicalization of disability. So medicalization refers to the way in which disability is inappropriately conflated with illness or being unhealthy. So I may experience pain daily related to my disability, but I could still be entirely healthy. And it's also the way that all disabilities are viewed as needing to be treated, cured, or prevented by medicine. And then medicalization is also linked to the medical field serving as the gatekeeper of disability. So regardless of the disabled individual's presence or absence of illness, medical practitioners are the ones who hold the power to withhold or grant permission for disabled individuals to access government assistance, social services, and workplace accommodations that they need to survive. So for example, remember how I had to get a letter from my surgeon to give me permission to stay within the nursing program that I knew whether or not my body could handle with accommodations, or how I need a letter from my doctor in order to receive accommodations from the Disability Resource Center or Illinois Department of Rehabilitation Services. These are just examples of how medicine serves as the gatekeeper of disability. So disability falling under the jurisdiction of the medical field increases the proximity of disabled people and medical providers, and it facilitates this hierarchy of power, with practitioners being situated above disabled people, and further justifying the need for healthcare providers to be aware of and combat ableism within their practice. And then these are quickly going over concepts of pity, inspiration, and infantilization. So pity, and this is actually what I experienced most with my peers. So I didn't really, My peers were never upset that I received accommodations, and they've never been upset about that, like, which is more the attitude that I've gotten from nursing faculty. Peers do have a lot of pity though, and I think it's rooted in a lack of understanding of disability because we get no education on disability within curricula. But there's like this overwhelming pity that non-disabled people feel for disabled people, and a lot of times it can be rooted in ableism. So when you look at a disabled person and the first thing you think is, that's so sad, I feel so bad for this person. That's what I'm talking about when I say pity. I think that pain complicates a lot of the things, and like, for example, with my story, that was an act of violence that somebody did against me, and like my disability was acquired based on that. So maybe that's a little bit different, but a lot of times people with congenital disabilities who are just living their life, like who didn't have an overt act of violence that caused a disability, and then people are just sad, non-disabled people are just sad for them. That's not okay. I think it's also important to think about like the harmful implicit power dynamics that's upheld by pity. So it says that non-disabled people are up here and disabled or at the top, and disabled people are inherently at the bottom. There's like a power dynamic when it's the person pitying the person being pitied. And in reality, disability and illness are natural parts of being a human. And there's a difference between pitying and empathizing and humanizing. Pity is really linked to the way that disabled people are viewed as an inspiration. And this isn't to say that there aren't disabled people who do some really inspirational work, just like there are non-disabled people who do inspirational work, but this is about like looking at a disabled person and being inspired by them simply for existing. I'm going to refer you to the TED Talk by Stella Young that's on inspiration porn if you haven't seen it, and we'll make sure we get you the links for those, but she says it best in explaining this like concept of inspiration, and that's linked to pity. I remember in elementary school there were always posters on like our walls in the hallways that said something along the lines of, if this person can do it, you have no excuse to not be able to do it, and it would like show a disabled person in a wheelchair or something like that. So disabled people should not be the motivation for non-disabled people to work harder. And then infantilization. So society and the medical field specifically do this so much with disabled people. They infantilize disabled people and desexualize disabled people. So infantilization includes viewing disabled people as these like eternal or perpetual children. And also many non-disabled people have a hard time conceptualizing that disabled people with physical, intellectual, auditory, and visual impairments and disabilities have sex, and that there's this view that like people with disabilities can never have true consent. Even people who are completely nonverbal are capable of having consent. And I remember I did my precepting on the women and infant postpartum unit, and there was a woman with an intellectual disability who had just had a baby, and her partner was a non-disabled man, and the entire floor of nurses was freaking out that she was being abused, that there's no way this woman with an intellectual disability could have consented to having sex and having a baby. In reality, there weren't any I didn't notice any signs of abuse. It was literally just because she had an intellectual disability, and this is ableism. This impacts the medical care and access to sexual wellness care for a lot of disabled people. Okay, and then I was going to talk about crip time and how disabled people experience time and space differently than non-disabled people, as well as the way that like disabled people have daily care for their impairments, doctor appointments, therapy sessions on top of all of the work that non-disabled people have daily. And like the capitalist push for rapid productivity is really exclusionary, ableist, and disabling, and the nursing profession has a lot of work to do with their perception of time and production. But I'm just gonna skip to disability justice. So there's a difference between disability rights and disability justice. I'm gonna give a really broad overview of that. So disability rights advocates for civil rights and self-determination, and it has historically centered the voices of white, economically privileged American disabled individuals, versus disability justice takes an intersectional approach to center and uplift disabled people with multiple intersecting marginalized identities. So the building blocks of disability justice include intersectionality, leadership of the most impacted, anti-capitalist politic, cross-movement solidarity, recognizing wholeness, sustainability, commitment to cross-disability solidarity, interdependence, collective access, and collective liberation. So disability justice politically acknowledges that the inextricable links between all systems of oppression and abuses of marginalized people, and that capitalist white settler colonialism, including the transatlantic enslavement, colonial invasion, and forced and unpaid labor, gave birth to and are inherently connected to ableism. So disability justice means, for example, that we can't talk about ableism without also talking about racism, classism, sexism, etc. And unlike disability rights, which approaches accessibility as a state mandated chore or an obligation required by law for non-disabled people and institutions to follow, disability justice calls for reimagining access as joyful collective care, rooted in consensual interdependence, solidarity, reciprocity, and mutual aid between and across both disabled and non-disabled communities. And this interability model works to eliminate the charity-oriented unequal power dynamics that's associated with the caregiver-receiver dichotomy, and also to the medical field, which is conditional and inherently risks abuse of power. So disability justice serves individuals who typically would be excluded from reaping the benefits of disability rights, such as non-citizens, incarcerated people, people who are houseless and ignored by the state. And it requires universal access be built into systems from their inception to benefit disabled people and non-disabled community members alike, instead of tacking on, how can we make this more accessible after the fact? And then interdependence. So this concept is really important to nursing in the medical field because we have such a heavy push for independence. Like that's a goal a lot of the time within nursing and for patients. And in reality, we are a social and community and interdependent, that's what we are as people. Nobody is actually independent. When our computer, our electricity, or our toilet break, we call someone else. When we're sad, we call someone else. We are inherently socially dependent creatures, and nobody is completely independent, yet we have this really strong push for independence, and it's related to capitalism and productivity within America and medicine especially. So interdependence is the term that acknowledges that the concept of true independence is a fallacy or a myth. And I think the best example of interdependence I can think of is between me and my best friend. We're both disabled, she's blind, and I have a back disability. And in middle school, and especially in high school after my surgery, our school used to put us in the same classes to help each other with our disabilities. So I would find her papers for her and read the board for her. And she would do like lifting for me. We link arms everywhere we go. So I guide her and she carries my backpack. This is one example of interdependence, and we all do it daily, disabled and non-disabled people. We just rarely take the time to recognize what we're doing. So essentially, interdependence rejects the capitalist hegemonic myth that humans are independent beings who do not and should not need each other to thrive. And then access intimacy is the experience of basically like walking into a space and not having to explain to the people around you what you need in order for the space to be accessible, it becomes a part of second nature for the community. So for me, my friends and community and classmates and sometimes professors know what I need when I walk into a space, that it's like a chair with a cushioned back and that I need help lifting things. So I can enter these spaces and it's like second nature, that's just part of like our interaction, and I'm accommodated for it, and I can't explain this feeling, but it's like very magical, and it fosters belongingness and humanization. It says, even though this environment isn't inherently accommodating for you, as a community, we care about you and we want you to be here. And then we already talked about CRIP wisdom or knowledge, but just to recap, it's like the skills or wisdom that are unique to disabled people that comes from impairment and disability experience. It's also called like CRIP emotional intelligence, and it means that sick and disabled people, among many other skills, are uniquely adept in adaptability, moving slowly and intentionally, and at reading pain and struggle beyond the surface, which are skills that might not come as naturally to non-disabled people. So I'm going to hand it over to Jen. Thank you so much for listening to my part. We're going to be talking about ways to support and advocate.
Thank you, Sabrina. Just real quick, does anyone have questions for Sabrina before I dive into my section, which is going to be more on ways to support and advocate? Feel free to ask questions while I pull up my presentation. Sorry, trying to figure out how to see my notes while still showing this to you. So do you guys see the notes? Probably, right?
Yeah, we do.
Yes. Okay, I'll take it out of that view. Thank you. Okay, so I am Jen Glayzer. I use the pronouns she, her, hers. I'm about 5'2". I'm laying down. I have sandy colored hair. I'm wearing a blue shirt, and my background is a church. It's kind of in a field, but you can't see that part. I identify as disabled, white, middle class, cisgendered. My office mate is an 80-pound bull mastiff, so you may hear him occasionally. He likes to interject. I am a PhD student. I'm in the 5th year of my program. I'm in the BSN to PhD program. I did work on the floor in mother baby prior to going for my PhD. I worked there for 1 year. I thought it was important for me to get that floor experience before going into grad school. And I was told that I would have difficulty getting into PhD program without doing it, even though I had research experience. Luckily with my experience, I was able to go right into mother baby. My disability is an invisible illness, meaning you can't tell I'm disabled by looking at me, but it presents in the way of a physical disability where I have issues with mobility and sitting, and I get sick frequently. So I would have difficulty working on a med surg floor, but working on mother baby, you usually didn't need to lift the mothers. And if you did, I could get help. And the babies are about 10 pounds. So I didn't have any issues there. So it worked well for me getting my experience. My disability has affected my career trajectory significantly. I didn't know that I had any problems until I was in my 20s. And at that point, my career path was going towards physical therapy school. And I was actually in a doctorate program for physical therapy school. But once I realized that being a physical therapist was not really feasible for me, I decided to leave. And I wanted to stay in healthcare. So I was like, okay, what with my background would be, kind of a quick transition. I still can work in healthcare. I can work with patients if I'm able to, I can work that in. And nursing seemed like a good solution because you can work with patients, but there's also jobs in which aren't physically demanding. You can work for an insurance company, you can do psych nursing. There's just a lot more options that physical therapy didn't lend. So I switched to nursing, got a second bachelor's degree in nursing, and eventually ended up at UIC. So for my PhD, I'm researching pain, specifically in vulvodynia and Ehlers-Danlos syndrome. I'm on the Chancellor's Committee for the Status of Persons with Disabilities, and I'm also a member of the Diversity Task Force for the Midwest Nursing Research Society, where we look at different issues with like conferences and whatnot to make sure we're being as inclusive as possible. I'm funded by the NIH, the National Institute of Nursing Research, Rockefeller University Heilbronn Nurse Scholar Award, the Ehlers-Danlos Society, Sigma Theta Alpha Lambda Chapter, and UIC, but I have no disclosures. Why is it? Sorry, it's not clicking. There we go. So an overview of what I'm going to be talking about: the who, how, and when of disclosing different types of disabilities, equity in the classroom, universal design, resources, and where to go from here. So disclosing. So this is kind of a tricky thing to navigate that people with disabilities go through all the time. So when you meet someone, you're like, do they need to know? How much do I tell them? And when do I tell them? Obvious ones to disclose are professors and advisors. And usually you're doing that at the beginning of the semester, and you have to decide if you want to do it in person or over email. Personally, I like to do it over email because it's just not as awkward as it's vulnerable having to tell someone, even though you don't have to say what the disability is, just disclosing it makes you vulnerable. And usually I give like a brief synopsis of the kind of accommodations that I need. But when you're doing so, even though they're required by law to give you the accommodations, sometimes if they're an inconvenience, they'll try to push back and say, well, do you need this? Do you need this all the time? And with the power dynamic, it becomes uncomfortable to navigate because you don't want to be a troublemaker. You don't want to go against them. Like, they're going to be deciding your grade. You're going to be working with them all semester. If it's an advisor situation, you're working with them for years. So you have to navigate it lightly so that that relationship is maintained, but you're still getting what you need. One thing that can be extremely helpful is the DRC, bringing them in when these situations happen, because they're very good at like smoothing it over and advocating for you. So you don't have to be the one to be like, I need this. Disclosing to classmates when you're working in groups. And then another thing that's often discussed is, should you disclose to scholarships or possible employers? The current theory of thought that's been talked about a lot is being open. And even so far to the point that putting your disability in your signature line. And this can open you up to discrimination. But the thought is, if you're applying for a job and they're not welcoming to people with disabilities, or they're going to discriminate you, it can be better to learn about it up front, because most of us want to work in an environment where we're going to be welcomed and supported. Scholarship opportunities, it can help you if there are scholarships for underrepresented minorities. It can help with that. For example, I have an F31 grant from the NIH. I applied through the diversity pathway, and that made it so that my grant was automatically made it to group. Oh, sorry, one other thing. If you have any questions at any point, feel free to raise your hand. I want to make this kind of like a conversation, so especially as I go through resources. Interject, or Sabrina, if you can keep an eye on the chat too, let me know. So next, how much should be told? Per the rules, we don't need to disclose about our disability, but when you're interacting and talking with someone, as Sabrina mentioned, there's almost like you feel like you do need to tell them, almost like an imposter syndrome, to like prove that you do need the accommodation, especially if you are getting pushback. And within colleges of nursing, because nurses always want to help, and our faculty are nurses, there is that inquisitive nature. And I don't think it's meant in a negative way, but they want to help you. So they want to ask questions. But again, that power dynamic comes in and you're like, okay, how do I respectfully decline sharing information? You know, if it's information that you don't want to share, or advice. So that can be a little tricky. So the person should only be disclosing as much as they want to disclose. When to disclose: beginning of semesters or as health status change. Again, as Sabrina mentioned, a huge thing is trust. So especially prior to COVID, attending classes virtually wasn't a thing, really. We didn't have the infrastructure at UIC available to make that available across the board. So with my disability, getting sick frequently, with all of the classes stacked on Wednesdays, if I got sick on a Wednesday, I missed an entire week of class, and that's significant. So being able to attend virtually when I was sick literally meant the difference if I could have access to my education. So much so that in one of my semesters, when I was particularly sick, one of my professors let me attend the entire semester via Zoom for my morning class. Without that accommodation, I would have had to drop that class, which would have made me part-time, which then would have made me lose my scholarship. So these access to accommodations can make a huge difference. But when I'm discussing this with a professor, I don't always want to tell them that to that extent, because it makes me vulnerable. And I was raised to be stoic, so I don't always want to like share those details. I think probably a lot of you have seen this image, but I think it's a really great depiction, so I threw it in here. So as you can see, all these people have the same box, which is equality, but everyone is different, so it doesn't really help everyone. Equity is making it so it's like an even playing field, but then justice is making it so that we don't necessarily need these accommodations, but we just have equal access because of the way the environment is built, i.e. universal design. All right, so types of disabilities. When we hear disabled, we often think physical disability in wheelchairs, so much so that when I was working on my PowerPoint design, I typed in the header disability and I clicked show me designs, and PowerPoint brought up this picture of a wheelchair. And this is the only picture they brought up. I was dying. So I was like, all right, I got to throw this up here. So all disabilities can present in a million different ways, and you can have more than one type. But here, these are just some basic types to kind of like bring some things to forefront. There's visual, hearing, and visual and hearing can both be invisible. Physical, cognitive, such as learning disabilities, mental, such as depression, or schizophrenia, and then invisible, as I had mentioned before, where you wouldn't necessarily see it. And with an invisible illness, I think deciding when to disclose can be a little tricky, because you can pass as non-disabled. So as someone with a disability, sometimes I won't disclose in certain situations because it's just like, if I'm tired, I don't feel like dealing with it. So even if I need the accommodation, sometimes I just, don't say anything, especially if it's a situation that's going to pass quickly. And also, you're not always believed. As someone that looks healthy, I am challenged more. And so much so that I had my doctor write a form so that I could get an ID from the state of Illinois that says I'm disabled, because Amtrak wasn't allowing me to have a disabled seat when I purchased my ticket. So with invisible illnesses, you definitely get challenged. So I'm gonna give some basic tips and tricks based on the different types of disability, and then I'm gonna go more into the different resources that you can access. So providing PowerPoints in advance, in like kind of the day before. This allows students to print out notes. For students that have issues with writing, this can cut down on the amount of writing that they need. Also, if you have a disability, you often have appointments with specialists, and some specialists only see patients on one day. If that day happens to fall on the day of your class, you're going to have to miss class occasionally. So we may be missing class more often, even if we don't have to. So if classes are recorded, we don't lose that access. And so I have recording lectures on the other side, but if you're able to record classes, this can be a huge resource for people with multiple disabilities. If you have ADHD and you're not able to concentrate for long periods, you can leave it and come back. If you need to take notes slower, or you have hearing issues, you could turn the volume up. You can slow the play down. UIC also has a very international, lots of international students as well as international professors. So with recordings, you can slow it down so you can understand it better. And there's the possibility for closed captioning as well. Providing the reading and some assignments in the beginning of the semester. So if a person knows that they're going to have a medical procedure or appointments that they're going to have to miss class, this allows them to work ahead so that they don't get behind. Using different mediums for teaching, especially for people with learning disabilities. So, providing a video on a topic in addition to, writing some parts out. So in your lecture, using different mediums. Oops, sorry, that pasted twice. Allowing cameras to be turned off during virtual classes. And this was kind of a hot topic for some classes during COVID. Some professors required the cameras to be on so that they know that the students are there and listening. I'm gonna take off my background for just a minute. So I work from bed. I have a difficulty sitting. This is actually my office and my desk is right there, but I always work from bed. This can be perceived as lazy by some people if they don't know me, which is why I have a background up. But especially when people are just starting to use Zoom and we weren't as familiar with backgrounds, it can disclose things about you that you don't want others to know. It can show your living situation. Sometimes when I have migraines, it's just too much and I close my eyes, but I'm still listening. So that may look like I'm sleeping. So for many different reasons, having the ability to turn the camera off provides some privacy. And there are ways to still check that people are listening. You can have, people check in with an emoji. Okay, have your students raise your hand. You can ask questions, have them chime in on chat every so often. So you don't necessarily need to be seeing them, even though no one wants to be talking to a black void virtually. Having food and drinks during class. Diabetes is an invisible illness, and so maintaining blood sugar, people may need to eat or have drinks for taking their pills. This can be kind of tricky with the drinks during COVID. Using the restroom, if you have a GI issue, you may have to get up frequently to use the restroom, so not needing to ask permission to leave the room. Also, when you do the syllabus at the beginning of the class describing that the resources are available, I know there's always the blurb in the syllabus, but many of my classmates know that I have a disability and I'm familiar with the resources at UIC, and they often come to ask questions because they're not familiar with the type of accommodations they can get. So, providing a few examples of the type of accommodations, or if they have questions, let them know that they can ask you, just giving a little bit more information about it. All right, next we're going to be talking about universal design. And it's the design of products and environments to be usable by all people to the greatest extent possible without the need of adaptation or specialized design. So as you can see, these stairs in the picture on the left, it has a ramp built in that is also stairs, so people can use it either way. There's 7 principles of universal design: equitable use, flexibility in use, simple and intuitive use, perceptible information, tolerance for error, low physical effort, and size and space appropriate in use. So 5, 6, and 7 tend to be more about your physical environment. And I know as professors, you can't really alter the classroom as much. I was going to focus more on the resources and the universal design for courses. Equitable and flexible use. So this makes design useful and marketable to people with diverse abilities. The design accommodates a wide range of individual preferences and abilities. So a key part of this is things are built in a way that people don't need to ask for accommodations, or they aren't separated out as needing something different, because the way that things were designed is equitable in nature and can be used in more than one way. So for example, if you were making a website, making it accessible to a screen reader, or if you have an online class and students need to do discussion posts, allowing the students to either type or do a voice record for it. So they're still contributing that discussion, but they're able to do it over different mediums of what they may be comfortable with. Or for their end assignments, allowing writing a paper or giving a presentation. And I forgot one point from the other tips and tricks slide, where with the schedule, if often, especially in the PhD program, there were papers for the end of the class, and knowing that ahead of time that they were all going to be due the same week allowed me to plan ahead a couple of weeks, because if I did all of my papers at the end, my hands would just be so shot because of my disability that I could barely write the last paper. And in my first semester, I didn't realize this, and my last paper was like a C, whereas all the other ones were A, just because I physically was unable to write another paper. Simple and intuitive use. Use the design in an easy to understand, regardless of the user experience, knowledge, language skills, or current concentration level. So this not only benefits people with disabilities, but also, as I mentioned, a lot of our students are international, so ESL. Making your Blackboard or website intuitive, so a format to it, where there, like, let's say you have all the assignments in one section, all the exercises in one section, and that pattern carries throughout, or a consistent structure throughout the course, so that people can navigate the resources they need to get to. Perceptible information. The design communicates necessary information effectively to the user, regardless of ambient condition or a user's sensory abilities. So throughout the design of this PowerPoint, Sabrina and I both made sure that we had slides that were readable. The font is large enough or larger and is contrast to the background color. The 3 fonts that are most readable are the Tahoma Helvetica veranda, and you shouldn't have a size font smaller than 24. There should be a good contrast in colors, especially for people that are colorblind. Now I'm going to be going over some UIC resources. So the DRC is an amazing resource, and we have some of the people here. I believe I saw Sophia and Hugo. How that process works is the student gets a note from their doctor that outlines their health problems. The doctor does not need to say what accommodations that you need. And a lot of people think, well, I'm not like identified as disabled by the government, but that doesn't need to happen. You just need to have an issue that requires an accommodation. You meet with a specialist and they help come up with your LOA, which is your letter of accommodation. And this is a super helpful process, because even as a grad student, when I met with my advisor or specialist, they had ideas that I didn't even know were possible to help me with my issues. Like, I didn't even think about a talk to type program. So that helps me with writing papers. So now I use a dictation software. So have them being in the field all the time, they can come up with a lot of accommodations that people don't know are available. Some of the accommodations are extended time on exams, assistance with note taking, seating accommodation, captioning, alternative text for books, and transportation. Kind of per DRC, but a little bit different, is the Disability Cultural Center. And so this can really help disabled students, and not so like in a different way. They have lectures on what I call life hacks. For example, when I'm sick, it's difficult for me to get food, because when I was living by myself, I wasn't well enough to cook meals, and I didn't want to always eat pizza all the time. So in a lecture, we talked about what different tricks were that people had done, like they cooked all at once and then they had frozen little portions. When they're sick, they had healthier food, or they knew about certain delivery options for healthier food. And so being able to talk through these problems with other people with disabilities helps give a sense of community. It also helps people navigate their identity as a disabled person, and kind of how the intersection of their different identities. So it's not only a cultural center, but also you can learn through the lectures. Another resource is the Chancellor's Committee for the Status of Persons with Disabilities. Sabrina and I are both on this committee, and we're on the Students' Experiences Committee. We help advise the Chancellor on the needs of people with disabilities. We have with faculty, administrators, and students. We've been giving input lately on the development of a quad, making sure the furniture is accessible, and just how they're designing it. So we try and give suggestions based on what's currently going on at UIC. And if you're interested in getting involved, it's a great way to do so. I've learned so much being a part of it. The Office of Access and Equity. So this form I have right here on the right, it's a report and IT accessibility issue. And this is the website for it. Is super helpful. So you can let them know, like, if you're in a virtual class, one issue we had is half the people were in person and half the people were hybrid. And the people in person couldn't hear the people online. The people online couldn't hear the people in person, but it was supposed to be a discussion course. So the conversation wasn't flowing, and it was really difficult to communicate. By filling out this form, they kind of looked into it, and they talked with the people in the College of Nursing to try and make the situation better. Lots of people don't know this form exists, so we're trying to increase awareness about it. Through the OAE, employees can also request accommodations. The College of Nursing also has diversity and inclusion. Through their website, they have information, and also where you can ask questions to Dr. Matthews, who is the Associate Dean for Equity and Inclusion. And I think there's also other ways to get support if you have a question. So teaching resources, UIC, from my opinion, has done an amazing job with diversity, and especially being on the CCSPD, I feel like they're doing everything they can to be supportive, and there's people working to make the situation better. I also feel that way about the College of Nursing. Dean Weaver had reached out to me about talking to me about the experience of students with disabilities in the College of Nursing. It really made me feel heard, and that, you know, this was an important issue. Same with Sarah reaching out to us about this meet and learn. So I think the College of Nursing is doing a lot of great things. It's showing that they're working at it. And as I said before, you can never prepare for every disability or every accommodation. What's most important is that you're willing to listen, trust, and learn. So there is what's called the Inclusive Classroom Initiative through the Office of Diversity, Equity, and Engagement. And this is still being built. Some of the modules are up now, and some of them they're still working on. But they walk through kind of like there's one that walks through kind of like the universal design that I was talking about before, and how to make sure your course is inclusive and other issues you may not think about. For example, when Sabrina and I were talking about disclosing our health issues, one tricky thing, as we mentioned about working with other people that are in the medical field, is that sometimes like your supervisor may want to protect you. We've heard of stories where, you know, maybe an advisor finds out you're on a certain medication. They think it's for X reason, but it really could be Y reason. And then they're worried, oh, maybe a side effect can be fainting, and then we don't want you in the lab because you could get hurt. So these modules help give different perspectives, because if you don't interact with people with disabilities on a regular basis, you may not think about these different situations that can happen. There's an accessibility resources and guides from the Disability Cultural Center. I've shared these resources with, for example, MNRS. It's a really great resource, similar to the module, where it just points out different things that you may have not thought of, kind of like the font size, using certain colors, trying to get closed captioning for larger webinars. And there's different guidelines for each of these 4 categories. Okay, so resources outside of UIC. Most people I know haven't heard about the Illinois Department of Human Services Rehabilitation Services. So every state has a Department of Rehabilitation Services. Sometimes they call it something different, but their goal is to help people with disabilities find and retain jobs, to keep us employed. And they also work with students, but there's such a huge variety of the accommodations. They have a special list of jobs where companies are looking for people with disabilities to hire. So you can get like help with the hiring process. If a company is unsure about hiring you, they'll cover your wages for the first month as a trial period. I worked with them in the state of Michigan. When I finished my BSN at Michigan State University, the Disability Resource Center there automatically funneled me into rehabilitation services through the state of Michigan. I had no idea they existed, but they met with me. And at the time, I had been hired by a hospital to work in mother baby. And so I met with the advocate prior to starting, and they were able to help me anticipate the kind of needs I have, and help me get in contact with the HR disability person. And it was also just very comforting to know that I had someone supporting me. So if I received pushback, I had someone from the state that knew the law, and I could ask them, is this okay? Is this not okay? What do I do about it? And just not feeling alone was just it was so great, because in nursing, outside of Sabrina, really, I don't know many other people that are disabled. So navigating that is tricky. As a student, they've been amazing. They've provided the dictation software for my hands. They've actually picked up my tuition for 2 years. I was a TA and it was covered. And before I got my F31, rehabilitation services covered my tuition. And how that worked was because I'm no longer able to work on the floor. So they see this as training so that I can get a job that I am able to do. Because of my disability, my inability to sit, it limits the type of jobs I can do. So they saw this training as a way to keep me employed. As I mentioned, they help students transfer from student to work. And having that extra support is priceless. And then navigating disability in the workplace. I wouldn't even known that HR had a disability person. So they helped me find that, think of the devices that I would need. So the process for rehabilitation services is much like the DRC, where I had a doctor just explain what my health problems were. I don't need to be identified as disabled by the government to receive disability or anything like that. The one thing I will say is that they're under supported. So you have to be on top of it, contacting them and following up. Their website is down here, but this is a good thing for the College of Nursing to know about, because if you have students with disabilities, letting them know about this resource can help them then with the next step in their career. Within Chicago, there's lots of different resources. The Mayor's Office for People with Disabilities, they can help with housing, navigating emergencies such as COVID. I think they had legal, transportation. So the access living is similar. And then the Chicago Lighthouse is specifically for vision. So these kinds of resources are important because students with disabilities, sometimes they have other financial burdens such as medical costs, or they're not able to, a lot of my classmates will moonlight to make some money in an ER or whatnot, but I'm no longer able to work on the floor. So I can only go to school. So finances are a little bit tighter because I'm not able to pick up that second job. So there's other obstacles that occur when you have a disability, and these resources can help navigate those things so that it makes it possible for you to attend nursing school and allow you to focus more on nursing, on your education or nursing, and less on how do I be a person? So how can we improve as nurses? I was at the Midwest Nursing Research Conference last week, and the Emerging Scholars Network luncheon, he had a talk about diversity, equity, and inclusion in nursing. And diversity is a hot topic right now, and a lot of people are doing things to make sure that we have we're hiring diverse amounts of people or diverse people, but there aren't always the things in place that help the people stay in those jobs. So how can we shape nursing so that it's inclusive and we retain people with disabilities? It's important to have a sense of belongingness. As I talk to other people with disabilities within healthcare, we feel like we're not seen. People assume that we're not there because of technical standards. How could we have made it through the program? And we feel like it's not a place for us because of sometimes the rigid work schedule of healthcare jobs such as 12s. It's difficult for us to be there where we could do the job, but we would need to do it a little bit different. For example, I didn't go straight to med surg because I physically could not do that. Thankfully, I was in a smaller hospital and they didn't mind me going to mother baby. Within the chat, there's been talks about technical standards and admissions. I tried to look up UICs. I couldn't find through the website. But this is happening throughout healthcare in medicine as well. There's been lawsuits that have been brought, some of them won, some have been lost. And at least in med school, the argument is like, do I need to do all the training if I'm going to be like a psychiatrist? Do I need to be able to make the technical standards of a surgeon? And I think you can also apply that to nursing. If you're going into psych nursing, yes, you still need to be able to lift, but we have lift teams, but you're not going to be lifting to the same extent that you are going to be on med surg. Or if you want to work for an insurance company, there's different ways to work that you can make it work with your disability. So having an understanding within the technical standards that they are a barrier and we need to find a way that's more inclusive. Be an ally and speak up. So when you hear people talking about these types of issues, just confirming that we are here. People with disabilities, it's not always visible, so it's hard to know if we're here. And that also comes into the mentorship issue, where it's hard to find people in academia with disabilities. I would love to know, other people and see how they've navigated academia as a person with disabilities, but I don't really have access to those resources. The only thing I've been able to find is a Facebook group called Disabled Women in Academia, and they're from all over the world. And so we chat about what universities are friendly, how do you navigate disclosing when you're hired. So, I'm not really sure the best way to go about this, but being able to provide mentorship for students with disabilities. And even as a student, I would be happy to mentor undergrads or students coming in that are facing these things. And right now, I think we have somewhat of an informal way of doing that, like Sabrina and I working together, but we don't know how to identify each other to help each other. And so that is kind of tricky because of the privacy issues. Building an environment where people with disabilities can thrive, so on the floor and in academia. Once again, thinking that people with disabilities can't be on the floor when you can absolutely have accommodations to make it work. One of my accommodations, because if I worked too long, it would take too hard of a toll on my body, I was only allowed to be scheduled 3 days in a row because I would always be sick on that 4th day. And we did 2-week blocks. And if you backed them up together, it was too much for me. So with the help of the rehabilitation services, I was able to get that, and they never did more than 3 days in a row. I had it with another nurse on my floor. She only had one hand, and so we would help her with certain things, and this didn't make her any less than. We didn't think any different of her. Nursing, we're taught to work in teams, especially in research. No one can know everything. You shouldn't be doing it on your own. So it shouldn't be any different when we're helping each other on the floor. And same with academia. Something I've encountered and I've heard from other people is like within the tenure system, and academia jobs tend to be one way. They're full-time tenure track, and that isn't always conducive to people with disabilities or people that have different lifestyles, childbearing people, people with families. So, having that conversation of, will there be changes in academia that can support different lifestyles? Any questions? No.
This was just an amazing presentation. Thank you both so much. I think I can speak for everyone in saying that I'm sorry that you've had to go through so much trauma and ableism that you faced, and we appreciate you being willing to share. And thank you. This is such valuable background, education, information. I really, really appreciate all the work that you put into this.
Thank you, sir. And honestly, I do really appreciate the UIC College of Nursing for putting this together. I have I've been in a lot of universities. I think this is the 4th university that I have attended, and I have been impressed time and time again with how UIC has reached out and tried to improve and is working towards it, acknowledging that there's room for improvement. So I really do appreciate it.
There's definitely room for improvement. There's no doubt about that. Does anyone have any questions? Thank you everyone so much for attending. Please remember to fill out the evaluation so you can get your continuing education. Thank you again, Sabrina and Jen. This has been so enlightening, and it's such important work and such important discussion. So thank you again. Take care.
Thank you.
Bye.